Okay. Last but not least, we gave you a bit of an open brief on any of the questions. Particular themes came out from your discussion?
We decided to adopt David's concept of the people's NHS, so we framed the people's questions, and the people at this table are going to heckle if I get anything wrong here. So with the People's Republic of Table 5, we wanted to talk about who's responsible and how is it going to be different this time. The first topic we came to was that it's different this time because of failure, because there's going to be an explicit failure regime, and because the Health and Social Care Bill, as it's currently constituted, actually allows for the first time properly for the possibility of organisations failing. One of my colleagues quite rightly raised the issue of thinking about banks and being too big to fail, and of course in geographic localities where a provider organisation there is no alternative, then I think we're likely to see some sort of, the government that have been the shape of the NHS Commissioning Board or perhaps the Department of Health becoming the lender of last resort to those organisations. We then started to talk about NHS management culture, which has obviously been touched on extensively throughout the inquiry. What did we say about that? We said quite a lot, didn't we? We said it was very centralised. We said it was very top-down. We said that the creation of general management following the Griffiths report from 1983 had effectively created this class of people whom effectively politicians can sack when things go wrong. And that's roughly, that's not going to be the future in the manner of CCGs as they're currently constituted. That role isn't going to be there, or certainly theoretically ought not to be there. We then went on to look at the issue of greater GP involvement in making decisions about rationing, because that's ultimately all we're ever talking about in a resource-constrained system. GPs are staggeringly popular and trusted with the general public. The figures, well over 80% of the general public consider that you people who deliver the vast majority of our care, we think we can trust you, we think you're going to do everything terribly well. So we certainly had an interesting thought that it would be very interesting to see what's going to happen to those levels of trust going forwards.
For when they become managers.
In the new system. We kind of felt at the table, I think, that the GPs are actually not managers in a particularly meaningful sense as we tend to be constituted now. Yes, they have their businesses. Those businesses are generally relatively small, in fact, and very often have practice managers who are doing much of the work that we would probably traditionally regard as management. So, trust and popularity, a couple of issues for the GPs who will go on to become the leaders of CCGs. Involving the public authentically, I was just very reminded of a quote from the American comedian Bill Hicks. He was talking about relationships, and he said the secret to a relationship is sincerity, and once you can fake that, you've got it cracked. And effectively, that's kind of the NHS historical tradition of involving patients and the public, which has been to fake sincerity. So clearly, if CCGs are to get this local legitimacy, which is incredibly important because they're going to have to lead decisions about closing maternities and closing A&Es and doing all those kinds of things, which by and large, the NHS old school management has a process and a series of hoops, and if you jump through all those hoops and have all those meetings on a cold Wednesday night in halls, eventually you can kind of do what you want, and judicial review hasn't tended to overturn you. But we were also very clear that with authentic involvement of patients and the public, we need to avoid the risk of kind of single issue capture and of the usual suspects tendency. I was fascinated to hear the phrase about hard to reach groups, and again I was reminded of something which Dr. Phil Hammond has frequently said about hard to reach groups, which is that people who sell alcohol, fags and drugs seem to find them remarkably easy to reach. So there's possibly a piece of learning to be done there. We felt that as part of that engagement, communication was likely to be extremely important to CCGs. and my personal observation was that it's fascinating that we seem to be planning to have a kind of centralised communication strategy for CCGs, and that's possibly somewhat counterintuitive. But the new media and social media, while not any kind of solution in themselves, offer CCGs a relatively low-cost, potentially kind of quite useful means of both broadcasting their messages but receiving messages from the public in a relatively convenient and, as I say, cheap manner. And we are going through the years where things that are cheap are likely to be things that are good. So yes, communications is obviously going to be very important. Can you tell which table had two journalists sitting on it? The importance of analytical and data skills was also something that we touched on. That's hugely important if we're to see commissioning make better rationing decisions and to actually notice when things are going horribly wrong. And one of the reflections that we had was that that's going to require firepower. That's going to require things which there might be further discussion to be had about whether emerging organisations with budgets of between £25 and £35 per head are likely to be the best level for which that kind of data analysis process will happen. What have I missed, guys? People's Republic of Table 5?
A pretty comprehensive list of things for us to consider. That's some good points there. And
about rationing.
yeah,
Because I get irritated, not in your case, of course, about rationing being used when actually we're trying to rationalise care. The definition I learnt was that rationing was a delay or denial of appropriate and effective interventions. The trouble is we do a lot which aren't appropriate and effective, and that's what we should be rationalising, not rationing. But the word is used so loosely that it gets in the way of any decent discussion.
yeah. So one is a positive thing, one less so, but we conflate the terms. Very good. Any final points before we draw some conclusions? Things that haven't come out through the day that you'd like to raise? Yes?
Just one point, not everyone may be aware of it, and if you are, well, training. In most CCGs, the GP leaders, which is very different from PCTs and previous organisations, are elected and not appointed. That means that you've got to do things right. Your colleagues have got to perceive that what you're doing is making a difference. Otherwise, you won't be in your post again next year or the year after. And I think that's very, very different from the current system.
Sure, and Andy's point, it makes it difficult for the powers that be to sack you as well.
It's difficult to sack you. It makes it very difficult for you to make difficult decisions when times are hard. But it does make you more accountable, certainly to your clinical colleagues. To your clinical colleagues.
Not to the public at
Not
large.
to the public.
The other mention all day is about the responsibility to commission the workforce. Now, I appreciate that much of that's done at national level, etc. But local commissioners in the future need to have a responsibility to make sure the right staff are in the right place at the right time to deliver all the things that we're saying, and that's an extra dimension that perhaps we haven't touched on.
So that might be one of the other indicators that they would look at.
Absolutely.
In whether a service is correctly constructed and